Good evening, everybody, and welcome to this evening's Twilight Online HIV, a GP's Guide to Pre-Exposure Prophylaxis webinar. My name is Samantha, and I am your host for this evening. Before we get started, I would just like to make a quick acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work. Before we jump in, I just want to introduce our presenters for tonight. So we have our facilitator, Dr. Andrew Knight, and our presenter, Dr. Nathan Ryder. So, Andrew is a GP staff specialist at the Fairfield Hospital GP unit. He's a research director for Integrated Care Southwestern Sydney Local Health District. He's chair of the Nepean Blue Mountains Primary Health Network, clinical advisor to the Improvement Foundation, and conjoint senior lecturer at the University of New South Wales. Nathan is a sexual health physician with 15 years of experience in HIV management in urban and rural Australia. He's a clinical director of sexual health at the Hunter New England Local Health District, the HIV support program coordinator at the Hunter New England Local Health District, and a conjoint senior lecturer at the Kirby Institute, University of New South Wales and University of Newcastle. So in saying that, welcome Nathan and Andrew. Thanks for joining us tonight.
Thanks very much. Great to be here.
Fantastic. And I will hand over to Andrew now to take us through the learning outcomes for this evening and kick off the presentation.
Well, thanks very much. It is a pretty exciting time to be involved in this work because I guess in my career I've seen HIV go from a really serious heartbreaking death sentence to something that's controlled, and now to something that really hopefully will be largely preventable. So that's pretty exciting. So tonight really is to discuss three things, or three learning objectives. We hope by the end of this meeting you'll be able to discuss the changes with regard to the access to pre-exposure prophylaxis through the PBAC, very new, through the PBS, very new announcement. Describe what it means for you in your working life, and also to list a series of clinical resources which will help you in prescribing PrEP. So what is PrEP? Well, it's an acronym for pre-exposure prophylaxis. So it's a daily medication that can be taken by HIV negative people to prevent HIV infection. So just by way of introducing the topic, we thought we'd ask you to answer a question. And that is, have you had patients asking for PrEP? So these polls are kind of fun. Don't know if you've done them before, but you simply answer yes or no according to the question, and do it as quickly as you can. We'll watch it get totted up, and then we get an idea of how many of the 182 participants on this webinar fall into each camp. So away you go, answer the question and we'll see what happens. We've closed it. So you can see that, I don't know if you can see the results, there you go. 70% of you are a no, but 31%, almost a third of people have had people coming in and asking for PrEP. So that's fascinating that it's out there, and certainly the people for whom it's a risk are in the know. All right, we'll keep moving along. So why PrEP and why now? Well, it is part of a strategy. What really has been an effective strategy. In New South Wales, there's been a really effective strategy looking at HIV over the last couple of years, and it's stretching through to 2020, aiming to virtually eliminate transmission by 2020. There's been a lot of work done on this in getting people onto treatment who are diagnosed quickly, but this new strategy, or it's not that new, but it's certainly new in terms of access to PBS, is a key plank in the strategy. And that is the prevention of HIV through the use of PrEP. So PrEP availability, up until now, you've been able to get PrEP in three ways, and many of your patients may have done this. The first is the EPIC study. We're going to go into this in a bit more detail. Nathan's going to tell us a bit about this. Second of all, personal importation, and this is something which many people have done, and there's advice available about this. It's quite practical to do and legal to do. And finally, private script is the other option, a much more expensive option. But Nathan, I think you're much more across the environment here, and I'd appreciate if maybe you can tell us a little bit about these methods.
Sure. So I've got patients at the moment using all three of those methods. I think we're going into a bit more detail exactly about how EPIC works in a couple of slides, but just give a bit of an overview at the moment. So the overwhelming bulk of people are accessing PrEP through EPIC. I think we've got about 8,000 people in New South Wales. So that's a clinical trial framework. So there is obviously some organisation around that. But not everybody is eligible for that study, and not everybody wants to take it in that way. So people that aren't eligible but still feel they're risky enough to warrant it, some of them are personally importing it. And we know the quality of imported drugs is pretty good. And so I'm very comfortable with that option. And we've got a few people still just buying it. So it's $25 a tablet at the moment through the before the generics came out. And some people that didn't want to take daily PrEP but had quite predictable and limited periods of risk were just purchasing it themselves. And a number of GPs had referred people in to me to get some advice around how to do that. And then they'd just see their GP when they needed a single bottle to take, usually for an overseas trip. So yeah, so people are using all three of those options, and we expect that will probably continue once it's been on the PBS. So in terms of the efficacy of PrEP, so PrEP's been studied a lot, and we've got a really good understanding of how well it works and what some of the downsides are. So in the clinical trials, we found that if people take PrEP, that the overall efficacy was around 90%. But if you then drill down a bit further into that 10% where it was failing, what we found was that the vast majority of that group either probably had HIV infection already and had tested negative on the initial test because it was very, very early, or the other group weren't actually taking the tablets reliably. So if you look at the group that definitely did not have HIV and definitely took their tablets, then there's been only 3 failures so far globally out of several tens of thousands of people. So we think the actual effectiveness, if it's being used properly, is pretty close to 100%, which is absolutely amazing. So yeah, if you move on to the next slide, that just summarizes that. So essentially,
it needs to be taken correctly and consistently, and adherence determines efficacy. And the idea is to take it daily. Let's move along. So in terms of safety, reasonably long trials, and there you see some of the comments about that. The common side effects are not severe, usually noticed early on, but subside quickly. Less than 2% of adverse reactions, yet less than 2% of users Truvada, and they report headaches, abdominal pain, and weight loss.
So yeah, so the longer term, I guess, real safety things as opposed to annoying side effects is around renal function and bone mineral density. So we know that tenofovir, that's really the main active ingredient, does cause a decline in renal function. We mostly see that in people who have pre-existing renal function or other risk factors for renal disease. So a big part of the initial assessment is trying to establish that. And although you do get a decline initially, generally with long-term use, it doesn't continue to worsen, particularly with time. The second thing, which is very similar really, is bone mineral density, that we do see a decline in bone mineral density, but for the overwhelming bulk of people, it's not clinically significant. The only people we're concerned about are people that have pre-existing risk factors for osteoporosis, and in which case then obviously for both of those two things, it might be contraindicated, or it might be a matter of weighing up two risky things and determining for that individual what's best for them. And I guess the final risk, which we're not really seeing much in practice, but it certainly can happen, is that you could develop resistance to the antiviral drugs should you contract HIV. So in the studies, that's been pretty rare. It's mostly happened in people who have pre-existing HIV and weren't taking their tablets reliably. We think in the recommended use, the rate of resistance would be very, very low. And even the resistance we do see generally has very minimal impact on their treatment.
Nathan, we've had a couple of questions about some of the earlier slides about PrEP on demand and also the requirement to take it for 4 days in order for it to be effective. Can you just comment on that? It was the end of the efficacy, I think, taken correctly and consistently and adherence.
Sure.
You said
Sure.
4 days.
So currently what's recommended is that people take it daily, and that's because that's where the evidence is. So there's a lot more evidence for daily PrEP than there is for other types of PrEP. In that circumstance, you need to take it for 7 days if it's penis in anus sex that you're having, or 3 weeks if it's penis in vagina sex. So that's before it becomes active, and that's around the amount of time it takes for the drug to get to the right levels in the tissue. So rectal has a lot higher perfusion of the drug into the tissue, so it's faster. You need to take it for 28 days after the last episode of exposure, and as I said, recommended daily, minimum 4 tablets a week. There has been a couple of studies looking at on-demand PrEP, and that's basically taking a couple of tablets before sex and a couple of tablets after sex. So in the studies, that's only really been shown to be effective in people that were having risky exposures multiple times per week. So in the end, they were taking quite a lot of tablets per week. We don't actually know how well that would work in someone who is having very infrequent episodes of sex, because then they're obviously going to have a lot less drug in their body. So at the moment, it's an option, and you could talk to the patients about what the studies have shown, but it's not recommended as a routine course of treatment.
Okay. Another question about that is, what efficacy rate can we say to patients if they take it reliably 7 days a week? 99% effective?
Yeah,
what do you think?
yeah. Well, that's a really good question. So I mean, I just say honestly that in the studies it's 90%, but most of those people, had reasons they contracted it. In use, we think it's probably close to 100, but I can never tell anyone that anything's 100% in medicine, unfortunately. So there is an element of risk there.
Yeah. And there's a question about acronyms, TD/FTC. What do those acronyms mean?
Yeah, well, they're the component drugs. So it needs to contain tenofovir and anthracidamine, and they're just acronyms for those drugs.
Okay. All right. So EPIC has been the major way that people have accessed PrEP to date, and it was before the PBS question has been answered. It was framed as a study. The next slide. So that's what the acronym stands for in EPIC, Expanded PrEP Implementation in Communities in New South Wales, led by the Kirby Institute, funded by the New South Wales Government, with a large-scale rollout to high-risk people. So it's a real-life implementation study with evaluation. And it's been a major undertaking. So a lot of clinics involved. It's been going now for a couple of years. It aimed to enrol 3,700 HIV negative people, and as Nathan said, we're now up over 9,000. So that's been huge. So Nathan, do you want to talk to what the study has shown us? I think there was some recent findings presented.
Yeah, so the early findings from the study were presented only really quite recently at the International CROI conference, and it's been quite amazing what we found in the study. So obviously we can't draw 100% conclusions that EPIC has led to these findings, but essentially in 2017, 11% fewer people were diagnosed with HIV in the previous 6-year average. So that prior to the sort of move toward getting more people on treatment and getting people on PrEP, we were seeing the HIV notification rate increasing. So having a turnaround and such a large turnaround is really, really encouraging. And if you drill down to the details, it gets even better, that the number of early stage infections decreased by 29%, because obviously we can't do anything about later infections from PrEP. And then additionally, if you look at the group that's really accessing PrEP, that's MSM or gay men, so there's been a 44% decrease. So really, rolling out this PrEP in a huge way, and it's probably the largest PrEP rollout globally, I believe. seems to coincide with a massive decline in new infections in the group that we're targeting for this initiative, which is really encouraging. And if this continues, it's going to have a huge impact on the overall HIV rate and the health of people at risk of HIV.
Do you know, Nathan? I don't know, and I'm asking a question without notice. Do you know if the plan is to continue EPIC given the changes in availability of PrEP on PBS?
No. So it was always in the clinical trial protocol that this was really a demonstration project and a way of getting in use data before it was available. So all the patients have been consented that they'll get a grace period and then they'll roll over onto accessing PrEP through the PBS. But of course, not everyone has access to Medicare, in which case they don't have access to PBS. So that's going to be a bit of a challenge for the public clinics, is how we can use personal importation and other compassionate means to make sure PrEP's available to everybody.
So what we're referring to is the recent decision, the recommendation of the PBAC that PrEP be listed on the PBS, and the government accepts recommendations from the PBAC, and that means it's going to be available to patients through Medicare, and it will be listed, we're thinking, on the 1st of April, which is really soon, and it'll be listed as an S85. And what that means is that at the moment, HIV medications are listed S100, which means highly specialised drugs and there's prescribing restrictions. But S85 means general schedule and any doctor can prescribe it. And so what does that mean for you and me? It means that we're going to be able to prescribe it to anyone who holds a Medicare card, and it means we need to be prepared for people walking through the door requesting PrEP, and this webinar is part of the preparation for that. We had it planned before the announcement, but I know that the planners knew that the announcement was coming, so it's also been partly for that. All right, so just thinking a little bit more about the HIV strategy, it's really set the scene in New South Wales with regard to HIV. The goals of the strategy up to 2020 is to virtually eliminate HIV transmission by 2020 and sustain it in people, particularly in people who inject drugs, sex workers, and from mother to child. And it focuses on priority populations and in a range of priority settings also identified, which includes general practice and primary care. Increased testing by you and me in general practice will be a key driver for achieving the goals. Most, as you probably know, most STIs and HIV diagnoses are made in mainstream general practice. And we have the contact with the unlikely patients. So, for example, heterosexual people who may not know they're infected and who will not come into contact with sexual health clinics as they don't consider themselves at risk. So what is the data telling us about HIV? Well, here's some data. In 2017, there were 313 infections with HIV. Now, I'm a bit confused about this, Nathan, because we're saying there's an 11% reduction on the year before. That doesn't look like an 11% reduction on the year before. Are you familiar with this data? Does that make sense to you?
Yeah, look, sometimes when you try and transfer across two different data sources, they don't always 100% match up. But yeah, the 11% is definitely correct.
Right. Okay.
So this is the number of newly diagnosed cases. So that's probably potentially a different way of cutting it.
Okay. The number that's been quoted in the data that we were given to give you is that the previous 6-year average. Well, okay, so the previous 6-year average was 351.5. So the previous 6 years, on average, 351 diagnoses. This year, there's 313. So I think we're seeing a trend there, certainly seeing a trend there in a reduction in diagnoses. So the key messages from the HIV data, Nathan, do you want to comment on these?
Sure, yeah. So yeah, this is really just pulling out what is a massive surveillance exercise into the main key points. And like we said before, the really headline number is the slightly more than 40% decrease in HIV among Australian-born men who had sex with men, and even larger decrease in early stage infections. But what we are seeing is that we're seeing an increase in overseas-born men of sex with men, and an even larger increase among heterosexual people. And they're the two groups that probably haven't been accessing these prevention methods as much as Australian-born MSM have. So we know that in the EPIC study, compared to what the notification data is showing us, we're not really reaching those overseas gay men in the levels that we should be. And the heterosexual increase is a bit more complicated because we're not even really confident that heterosexuals at risk are really even testing enough yet, and certainly accessing treatment less often than gay men are. So there's a lot of work to be done in those groups.
Yeah, and that's where mainstream GPs come in, people who see people in the community. It's worth realising that it's not the majority of these diagnoses are made in general practice. 41% of new HIV diagnoses in New South Wales were made in general practice, and of these, 34% of new diagnoses were made by GPs not accredited to prescribe antiretroviral therapy. So they're not S100 prescribers who may have a skewed practice population, actually mainstream general practice. And the key message here is that increased testing leads to earlier diagnosis, which is better all round. You get better patient health because they get onto treatment earlier, but also for the population, they're not infectious. So that means we get less transmission of the virus. So it's a really important message that we need to be having HIV there in our mind, especially when we hear about groups of people who may be at risk. So people who may have travelled overseas, people who have other risky behaviours. We need to be aware of this and be testing in the context of other STI tests to be finding these early diagnoses in these less predictable groups. It's really our job. All right, Nathan, a little bit more information about GPs and PrEP.
Yeah, so a lot of the highest enrolling sites in EPIC were actually GP sites. I think the highest by a considerable margin was a GP practice. And I think, whilst those are GPs that have had an interest in HIV medicine for a while, it does show that you can integrate PrEP into general practice setting. A number of GPs in my area, as I've mentioned earlier, referred people in for assessment and are prescribing PrEP off-label outside of PBS already. And we really think that PrEP is the ideal thing for general practice. It's a preventative health measure. It's very straightforward to do, but assessing people's risks for chronic diseases and interactions of drugs, which GPs are doing all the time, is really the only things you need to do. So I think this is a great preventative strategy for general practice.
Mm-hmm. So it's clearly something we're going to be involved with, prescribing PrEP. I wonder if you could just walk us through it a little bit, some of the considerations in prescribing.
So there's a great guideline. So I think there's a link on the page there now. So that's the Australian Society for HIV Medicine, or ASHM, and that's the national guideline. And it's pretty easy to follow, and I think there's lots of tables in there. And if you refer to that one, if you've forgotten what we've discussed tonight, you can't really go wrong. So I think if we flick to the next slide, it just steps you through the stages. So what you need to do. So you need to know when to offer or consider PrEP. You need to know what the eligibility criteria are, what the testing is, and what any other services there are. And I think the slides then sort of step us through each of those points, the upcoming slides. So yeah, so obviously the first thing is when to offer or consider PrEP. So this is when you might offer it to one of your patients, or if they request it, helping them work out if it's for them. So basically, it's recommended if people fall into the medium to high risk category. And that's essentially around their risk of contracting HIV. And that obviously varies depending on what they're doing and who they're doing it with. So the most common one I think by a long way, has been men that have sex with other men who aren't using a condom. And that would account for the overwhelming bulk of people currently accessing PrEP. If you're a heterosexual person and you have a partner with HIV, then you certainly could use PrEP. But we now know that treatment works really well as prevention. So it's only really someone who doesn't have an undetectable viral load on treatment, which is actually quite a small group. But we do have some people in that category, especially new diagnoses. Trans and gender diverse people, we would consider that a risk similar to men that have sex with men, especially male to female. Trans people have quite a high risk of HIV. And anyone that injects drugs and shares equipment, we think is high enough risk to warrant PrEP. So that's looking at their behavioural risk factors and whether they are high enough risk to warrant using PrEP. And then if we come on to the next slide, we look at the eligibility criteria. So once we screen them and think, yes, they're high enough risk, then we've got to look at both behavioural and clinical factors to see if yes, it's right for them. So we've sort of discussed the behavioural already. So the second part of that is the clinical assessment. And there's 4 things there, and they're all equally important. So the first thing is that they need to be confirmed to be HIV negative. So as we discussed before, there is a risk of inducing resistance, and therefore we don't want to give these medications to someone who's already HIV positive. So we need to test them. So we definitely test them at baseline, and we generally recommend a test at a month as well. We also asked about signs and symptoms of acute HIV infection because we know in that circumstance the test may miss it, and we'll definitely want to do a test at 1 month or not prescribe and wait.
Nathan, we've had a few questions. What about like men who have sex with men with if a partner's undetectable level and that's their only partner, should they be taking PrEP, or do they depend on the fact that the partner has an undetectable level, male or female?
I think the slide sort of simplified it somewhat. The guideline does step you through in more detail. But yeah, I mean, if the person has only got a regular partner and that person is known to have an undetectable viral load, then no, that we don't recommend PrEP. There is the odd person who takes it anyway because they don't trust that the partner is going to take their tablets. But on the whole, no, you don't need it in that circumstance.
Mm-hmm.
So the risk is mainly around unprotected sex with casual partners, and it's riskier if they're a receptive person than the insertive person. So there's a bit of nuance there as to exactly that person's level of risk.
Mm.
So once we've assessed that, the clinical stage, and the last ones I didn't get to was the renal function and the meds. Then I think you flashed up the STI testing tool. So that's from the STI Programs Unit website, which is a great tool to step you through taking a sexual history in a sort of simple and approachable way that's appropriate for general practice. It's got a really easy to follow table that tells you what tests to do, and then gives you some tips on collecting samples and contact tracing and whatnot. So that's a really good way of doing that sort of initial assessment stage. Then if you jump onto the next slide around testing. So this is the sort of baseline testing that you would do. So remember, we've done a HIV test. We do a full STI test at baseline, and we do that according to the Australian STI Management Guideline framework. So it will depend on the person exactly what test you did. We always test and vaccinate if not immune for hepatitis B because, as I'm sure you all know on the call, that tenofovir that is in PrEP is also a Hep B active drug, and we don't want to induce a flare by stopping and starting that. And finally, we generally consider testing for hepatitis C, although that's not generally considered to be sexually transmitted. In high-risk gay men, it probably can be sexually transmitted, and we think it's good practice to exclude hepatitis C.
Had another question. Another question, Nathan. You mentioned testing a month later, and there's a question there about the window period. Does that mean the window period has changed from what we were previously taught?
Yeah, so the official window period for a test is 3 months, and people get tested every 3 months as a part of PrEP follow-up. However, the vast majority of people test positive a lot earlier than 3 months. So the 1 month test is a practical way of identifying the overwhelming bulk of people who had HIV at initial test but tested negative. So the 3 month is 100%. Make sure you capture everyone. A month will capture virtually everyone.
Mm-hmm. Okay, thanks everyone. I'm trying to capture your questions as they come in. There's a lot of them, but we'll try and make sure we do address what you ask.
So I think if you speak to the next slide, so this is just a screenshot from the Australian STI Management Guidelines. So we said there's that STIPU testing tool, which is great. That's a PDF. This one's an online guideline. If you look at the populations and you look up, gay men or transgender people or heterosexual men, it'll quickly tell you what tests you need to do, and I can't recommend that guideline highly enough. And I think, the next one gets on to, so if we assume that we've got someone, we've done all those baseline tests, we've made sure they don't have any contraindications, then what we would generally do is write them a script for a 90-day supply. We don't recommend writing longer than 90 days. I haven't seen anything. I'm not 100% sure what the PBS dispensing units will be, but I'm assuming it will probably be 30 tablets of 2 repeats, because there's never really any reason you want to prescribe more than 90 days at a time, because you really need them to come back to have their monitoring tests. And as we discussed already, you need them to take it for 7 days before they can be considered to be protective. And so it says 7 days here. Most guidelines recommend a bit longer for vaginal sex, as I said.
Had a couple of questions about specific cases. What about sex workers, and what about people planning on sex tourism? Is there a difference?
Yeah, so I haven't had any sex workers requesting it, and the vast majority of sex workers use condoms. And if you're using condoms, that will be protective enough. Yeah, I mean, in theory, I guess you could look at it that way. The risk of contracting HIV for a female sex worker having sex with male clients in Australia will be extremely low, and probably wouldn't be worth the side effects for the majority of people. For a male sex worker having sex with males, it almost certainly would. And you'd have to have an individual discussion with them around that. But really, you should be able to apply the same principles as you do for your other patients. And what was the other one? The sex tourism.
Sex tourism.
Yeah. And look, I think that's going to be a big one personally. Not necessarily a huge market, but something that we will have to deal with and potentially can be really helpful for people. So that's the group I was saying before that I've had a number of people buying it at the moment because they go overseas. We know that overseas acquisition is a big issue for heterosexual people in Australia. Often they might intend to use condoms, but drugs and alcohol get in the way, and they know that's going to happen. And so PrEP's a really good backup strategy for them. So in that circumstance, that's where I'd say start 7 days before, use it when you're there, keep going for 28 days after you get back.
If we write a script today, can they get it after the 1st of April? It's probably not going to be in the prescribing software.
I don't think so. Yeah.
Okay.
I think, and we don't know yet whether, unless someone else knows, but as far as I know, we don't know if it's going to be a streamlined authority or not, in which case you need to know the code numbers and things like that.
Yeah, sure.
So ongoing monitoring education. So basically, it steps you out there what you need to do at baseline, and then the 30-day test, and essentially every 90 days from then on. It's pretty straightforward. It's mainly around checking for HIV and other STIs, and then checking for your kidney function intermittently. So this guideline is recommending every 3 months initially, and then every 6 months for an EGFR and a urine protein creatinine ratio. And pretty much then it just sort of links in with every time they come in for the next script, then you do the battery of tests. Hopefully the practice software will make a test set for this, because we certainly use it a lot in our system. So I'm not sure if we have any slides around the, So that's the sort of, biomedical monitoring, but of course there's more to it than that. So for the majority of people, they need some assistance with medication adherence. I'm sure I can't give any advice to a group of GPs about that. Just the same strategy that you're using for all your other patients are exactly what you need. People are a bit concerned about the side effects, so constantly reflecting on that. So for them individually, just reflecting every now and again on, is their level of risk still worth the possible side effects? And because that changes over time, obviously, especially if you've got an older cohort, starting new medications, potentially having declining renal function due to other things, it may change over a number of years, and you may decide to withdraw PrEP if their level of risk has gone down of HIV, but their level of risk of side effects has gone up. Obviously, PrEP is only protecting against HIV, so we do recommend condom use. A part of our starting PrEP is going through that and recommending that people think of PrEP as a backup strategy and to use condoms as often as possible. Obviously, for some people, that's straightforward for them and that's what they intended to do. Other people think, no, well, I'm taking PrEP because I want to have unprotected sex, and we take very much a risk sort of reduction framework there, and we sort of then talk to that person about, okay, well, I understand that, and what might be some situations where you might use condoms. Some people identify things like people that they don't know at all, or if they have sex while they're traveling, that sort of thing. Whereas if they've got a sort of a semi-regular partner, perhaps they might choose not to use it with them. And then we also talk to them about talking to other people about PrEP, because it has become quite a common thing that people will sort of ask each other about whether they're on PrEP and use PrEP as a prevention strategy. And that's probably got a lot of positives about it, but potentially some risks too. And just talking about the pros and cons of using what people will say about what they're taking as a definite means of reducing their risk. So that's mainly about the monitoring education. So the next slide goes on to the testing that we only do very occasionally.
Now, Nathan, there was one question about the monitoring slide. Do you know where that came from? It was a couple of slides ago, that little table that you had about the monitoring.
That'll be from the ASHM guideline that we flashed up earlier. Yeah. Sure.
Thanks.
So yeah, in terms of optional testing, so these things aren't done very often at all, but you might consider it. So if you're part of your initial assessment, you work out that someone's got some risk factors for osteoporosis, you may want to do a bone mineral density initially to determine if they do or don't, because that might determine whether you prescribe or not. And then obviously on an ongoing basis, you might monitor that. Same goes to vitamin D levels. And if you think someone may have early infection, you might think about doing a Provile DNA test. That's in the guidelines and it's been listed straight out of the guidelines. I would caution though that's not Medicare rebated, so the patient will be up for about $300. So I actually don't order that very often. I just order the normal serology test and do it again after a week or two. But if you're really concerned about someone might have early infection, I'd definitely encourage you to get some advice from your local HIV specialist.
The same issue applies, I guess, to bone mineral density. I don't know if being on PrEP actually qualifies you under the MBS for a bone mineral density.
No, it certainly doesn't. But there's not a lot of way around that. If you've got someone that's at really high risk and you're really not sure whether to prescribe it or not, and some people are quite insistent that they really want PrEP, you may well go down that path. I guess the thing with the Provile DNA test is there are other alternatives. You can just do the serology again, and it's almost as good. Yeah.
Yep. Is there a renal threshold if people have a certain renal function that you can't put them on PrEP? Is that how you approach it?
Yeah, well, the threshold for the EPIC study was 60, and that's pretty much what most of the guidelines say. So if your eGFR is less than 60, then PrEP's probably not for you. Although, I would say that there's probably some element there for some discretion and discussion with the patient, because ultimately you are weighing up the risk of renal disease against the risk of HIV. So if someone's risk of HIV is low, well, yeah, you're certainly not going to prescribe it in that circumstance. Whereas if someone's got an extremely high risk of HIV infection, they've got very stable renal function, say it may have declined through some disease or drug that has now been withdrawn, and then not really ongoing risk of decline, then I think in some circumstances maybe you would prescribe. But that's probably a good example where you might want to seek some advice.
Mm. And there was a question about interactions, and particularly with anti-malarials. I mean, if someone's heading off overseas on sex tourism and they take their PrEP, are there significant interactions with other medications?
So the main interactions is around renal risk. So we don't want someone taking a medication that is strongly nephrotoxic at the same time as the tenofovir, because that's your main concern. So the common ones that we've had is, so we've got people on lithium and we're having to closely monitor them. Another one would be very high dose non-steroidals. So there's a few reasonably common drugs that are reasonably contraindicated. Although, as I said, we've got some people that have very high risk, and we just monitor them monthly rather than 3 monthly. What I'd encourage people to do is to look up the interactions. There's a great website called HIV Drug Interactions, but presumably your practice software will do the same. It's very hard to keep track of the interactions with all the medications, I find, and so I just look them up.
Okay, we might press on. So there are going to be a lot of resources available to help. There's going to be an online learning module, a prescribing pathways, a patient information book, and when these are finalised, they'll be available from HIV as part of this program, and you'll be sent a link. You'll be able to access those. And the other resource is a phone line where we can ring for advice and guidance, particularly for complex cases. What's a complex case? I think got any ideas of what sorts of things people ring about for that?
Yeah, so that's a sexual info link, and you can ring that really for any advice around sexual health and HIV. Yeah, the complex ones that we get, probably around what I was saying before about weighing up that very high risk of HIV versus some degree of renal impairment or bone risk. So weighing up those two things. The other situation would be the one that you brought up around, say, sex tourism, and someone really wants to take it in an unusual way. So we often get some advice around the latest thing there. That's likely to change as more studies look at that on-demand PrEP and different ways of taking it.
Okay, great. Thanks. Look, the other thing we wanted to just speak about briefly was the whole issue of when we make a new HIV diagnosis. It's not a common thing that we do in general practice, but it does happen. And it's a point of significant interaction and point of stress in a relationship, and you really want to get it right when it happens. So there is a whole program to support GPs when they make a new HIV diagnosis. It's called the HIV Support Program. It's an excellent name. I'm wondering if any of you have heard of it or have had contact with it. We're going to do another poll and just ask you. So if you have had contact with the HIV Support Program or have heard of it, we'd like you to tick yes, just to get some idea out of the attendees. Now 238 attendees. What proportion have heard of it or had contact with the program? So there you go. Let's see what we get. Okay. Bottomed out. So 27% of people said yes and 73% said no. So about 3/4 of us have not had contact or heard of the HIV support program, which is hardly surprising because an HIV diagnosis in general practice, even though it is the place where most diagnoses are made, it's not a common occurrence. I'm going to tell you a little bit about it just so that you know it's what it is and how it works. So the next slide says that if you make a diagnosis, obviously wrapping care around that patient at the right moment, the right care that that patient needs, and helping you to provide care to that patient is key. So when you make a diagnosis, if you do a test and the test comes back positive, that test is by various methods notified to New South Wales Health, and your local HIV support coordinator will be notified. You'll be contacted and asked if you'd like help, basically. And then if you would, then the HIV support coordinator will give you a call and help you in providing the appropriate services for that patient. So I think it's an extremely good example of integration of care to provide the right sort of intervention for this particular condition. Obviously, things that we deal with commonly, we don't need that sort of support. But something that a really important event that happens rarely, we cannot be expected to be right across it necessarily, but it's excellent that the system provides the support at the right moment. So we talk about 5 key support services that an HIV positive person, a newly diagnosed person with HIV needs. And the next slide helps us to look at the pathway when it comes up. There it is. So you test, sent to the lab. The lab notifies the diagnosing doctor and the New South Wales Health HIV Surveillance Officer as a positive diagnosis. The HIV Surveillance Officer provides the details of the doctor who ordered the test to the local coordinator, HIV support program coordinator, based in your local health district, so they know the services available to you. And that person is a clinician with specialised training, and they will then contact you and offer help, depending on how much help you need. You can accept it or not. And the sorts of things I'll be encouraging you to do are around these 5 supports that every patient with a new diagnosis needs, and that's on the next slide. Obviously, we need advice about management, including treatment. Patients need psychosocial support at that point. And it's really important that the infection is not further spread, and so there's a whole issue of partner notification, and then the connection with specialist services in a timely way. So bad news is something that's part of life when you're a GP, and we get trained in it and we get hopefully better at it. And HIV in that sense is no different, but there are key specialist bits of information that we need about this. Okay, and we were supported to do that. Now we can also contact the support service if we go on to the next slide. So that if you haven't heard from them, there is a number that you can call to speak with a surveillance officer, and they can get you in contact with your local coordinator. So sometimes a lab might call you to advise that a screening test is positive, but yet, you know, there's often the confirmatory test may not have been done. So in this situation, you can certainly, you won't get that phone call until that confirmatory test is done, but you can certainly contact the service for support and advice. All right. So a couple of questions. What about pregnancy, Nathan? So if someone gets pregnant while they're taking PrEP, any advice about that?
So PrEP's not recommended in pregnancy at the moment.
Yep.
But again, you know, you would need to have an individual assessment there.
Yep. Okay. A few questions about people who are interstate, and look, I'm afraid I just don't know the answer. I know this applies in the HIV support program applies in New South Wales. I don't know if there are equivalent programs in your states. You'll just need to look into that yourself. I'm sorry. One person is saying it's not working as well as you might think, and then another doctor's saying actually it is awesome. They've had the experience and it has worked really well. All right, we're getting towards the end of our presentation, and so this is the conclusion. Important thing to know: PrEP is being listed on the PBS. The date we think it's going to be 1st of April, but this is to be confirmed. You and I will be playing a key role in HIV prevention, both through early testing, particularly in at-risk groups, and also through the prescription of PrEP to people who have at-risk behaviours and are HIV negative. And I hope now that you can see that there are really important tools and resources available to you to help in the prescription of PrEP and in the managing of HIV. So if we go back to our learning objectives, what did we hope we would achieve? that you would be able to discuss, be equipped to discuss. I say discuss because that's sort of a demonstration that you've learned something if you can discuss it. The information about the listing of pre-exposure prophylaxis for HIV on the PBS, and then to describe some of what that means for GPs, the actual technical aspects of prescribing, who to prescribe to, what to look for and how to monitor. And then we hope that you would be able to list some of the resources that will support you in doing this. All right, so thanks very much, Nathan. I think we've worked through most of those learning objectives, and I think we've looked at most of the questions that people have asked, certainly tried to. There have been a couple of questions about rates of STIs. There's a bit of concern, I think you raised it too, Nathan, that there may be some overconfidence or various reasons why PrEP users may be getting more STIs. Is there any evidence around that from for instance, from the EPIC study?
Yeah, well, look, we're certainly seeing more STIs, but we don't seem to be seeing a higher proportion of STIs. So it seems that we're just doing a lot more testing. So in the longer term, obviously there's a concern that it might change sexual behaviour overall in society and drive increased rates. But on the other hand, we're getting a bunch of people that in many ways were already high risk, and we're testing them every 3 months and treating them. So that may cause a decline in the STI rate. So I don't think at the moment there's any evidence, strong evidence either way. And so the definite population health main effect there is that we can virtually eliminate HIV transmission and possibly have an impact on STIs as well in a good sense. And so really there's no reason not to be doing it.
There's another question about the acronyms. Those acronyms refer to the drugs that are in PrEP. And yes, another question, if I said that PrEP was for at-risk people who are HIV positive, I was wrong. It's actually for people who are HIV negative, obviously, because we're seeking to prevent it. All right, I think we've done what we sought out to do. I'd like to thank you, the many people who participated. Over 200 people participated in this webinar. We trust it's been helpful. I'd like to thank Nathan for his expert input and to wish you a very good night. I think we're completed. Good night, everybody.
Fantastic. Thanks everybody for joining us tonight, and a big thank you to Andrew and Nathan, and everybody enjoy the rest of your night.
Thank you. Good night.
Good night.